Hello, good morning and good afternoon. Welcome to Moving from Spending to Investment, a research agenda for improving healthcare financing for children and youth with special healthcare needs. Next slide. My name is Chris Stilla. I'm a professor of pediatrics at the University of Colorado and Children's Hospital, Colorado, and I will be moderating today's discussion. We will also be recording this webinar, and it will be available on the Packard Foundation website in the coming weeks. Next slide. Joining me today are three great friends in our efforts. Meg Comeau is a senior project director at the Center for Innovation in Social Work and Health at Boston University. Dennis Kuo is a pediatrician and associate professor at the University of Buffalo. He's Division Chief of General Pediatrics at the University of Buffalo and an attending physician at Oishé Children's Hospital. And Jeff Schiff is a pediatrician and senior scholar at Academy Health. Next slide. Keep in mind, we're offering live captioning for this webinar. You can access the captions by selecting closed captioning at the bottom of your Zoom screen, or click the link in the chat to view the captions. If you're having any technical issues, please enter them into the Q&A box and we will try to assist you. Next slide. Please ask questions in the Q&A box. We'll hold the questions till the end of the presentation, but we'll have plenty of time for questions. We want this to be an engaging conversation and we encourage you to submit the questions. We'll try to get as many as we can today. And if we can afterwards, those we don't have time to address today, we will send to the presenters and post them after the session. Next slide. This webinar is part of 3 webinars that we're doing on the National Health System's research agenda for children and youth with special healthcare needs. I'm the principal investigator of the network that has created the research agenda with our partners. We are nearing the end of our first 5-year funding cycle as a cooperative agreement with the HRSA Maternal and Child Health Bureau. One of the major activities that we've done in our first 5 years is put together a national research agenda with input from multiple stakeholders over a long time. The rationale for doing this is that children and youth with special healthcare needs are a highly prevalent population, roughly 1 in 5 children in the United States, or perhaps even a bit more, and their numbers are growing. However, health outcomes have not changed a whole lot in the last 10 to 20 years, despite very well-articulated core outcomes that have been developed by MCHB, the Maternal and Child Health Bureau, and system standards which have been published for standards of care for children and youth with special healthcare needs. There's been substantial and growing research that's been done on this population, but outcomes have remained more or less the same. We put together this research agenda with the hope that it will both better integrate and prioritize priorities of families as well as other stakeholders, and to focus the research efforts that are being done by investigators across the US to drive improvements in healthcare outcomes. Next slide. The development had basically 3 parts. We started with essentially a consensus development process, the RAND UCLA appropriateness method, to set priorities and to level set those priorities across our different stakeholder groups back in 2017 and 2018. The first paper was published in Pediatrics in 2020, first authored by Dr. Ryan Collar. As soon as that paper was published, we realized that there was more detail needed to really flesh out the research agenda. So we sought additional stakeholder input with families, including families from diverse backgrounds, as well as different clinician groups that had not participated in the first go-round with the RAM process. We took all those data, put them together, developed 6 broad areas of research, and refined a set of research questions. The details of that are published in a supplement to Academic Pediatrics that was published in March of this year. You can see the first page of the first paper in that supplement on your slide. The supplement and all the papers in it are open access, so anyone can read them. And we hope that the supplement papers will help to guide researchers, funders, and other stakeholders in prioritizing research questions to look at. Financing is one of those 6 research areas, and we're going to talk about that more specifically today. Next slide. All right, I will turn it over to Meg Comeau to talk about our first topic and the paper.
Thanks so much, Chris. I appreciate it. It's a pleasure to be with you all here today. I wanted to spend just a few slides setting the stage for children and youth with special healthcare needs and healthcare financing in general, before we start talking in more depth about the research agenda itself and the proposed projects within it. So while we're all concerned with children's healthcare coverage and benefits and cost sharing and reimbursement in general, by definition, children and youth with special healthcare needs are higher utilizers of healthcare services than typically healthy, typically developing children are. So their associated costs are higher as a result. Financing for their care attracts more attention among payers, and the opportunities for improvement are greater. So that's one of the rationales for why there's a focus on children and youth with special healthcare needs and healthcare financing. Children and youth with special healthcare needs often require healthcare and related services from a broad array of providers, which make up a complex system of care. It's difficult for everyone to navigate. As a result, robust care coordination is required to ensure appropriate care, minimize redundancies and gaps, and maximize return on investment. Payers are obviously not the only interested parties in healthcare financing for children and youth with special healthcare needs. Adequacy, affordability, and continuity of coverage are significant challenges for families raising children with special healthcare needs, often resulting in family financial hardship and medical debt. And providers expend significant time and effort on essential but under reimbursed care. Next slide, please. I noted on the last slide that children and youth with special healthcare needs are higher utilizers of healthcare services and their costs are higher. The data presented here shows some specifics around those costs and highlights the need and opportunity we have for improving value in pediatric healthcare spending, using children and youth with special healthcare needs as a population focus. Next slide, please. So the data presented here shows that lower income families raising children and youth with special healthcare needs report better quality healthcare coverage. Quality being defined here as adequate and continuous coverage. This is explained by access to public coverage, chiefly Medicaid and the Children's Health Insurance Program, or CHIP, eligibility for which is income sensitive, and in Medicaid offers a robust benefit package for children under the Early Periodic Screening, Diagnosis, and Treatment, or EPSDT benefit. Next slide, please. The last slide spoke to adequacy and continuity of coverage. Increased affordability of coverage and benefits is also seen in Medicaid and CHIP, as demonstrated by this trend data. In 2018, 41.3% of families raising children and youth with special healthcare needs reported having public coverage only, and 15.8% reported having trouble paying medical bills for their child. In 2019, the percent of families raising children and youth with special healthcare needs reporting public coverage went down to 36.6%, and the percent reporting trouble paying medical bills went up to 18.2%. Conversely, reimbursement rates for providers tend to be better under private insurance. So how can we think about improving value in healthcare financing for all from an equitable standpoint, taking in the perspectives of payers, providers, and families? Next slide, please. One way is an increasing emphasis nationally on alternative payment models, or APMs. The majority of APMs to date have been designed and tested with adult patients. The aim of an APM is to increase value in healthcare financing by pairing reimbursement with increased quality. There's a continuum of payment models aimed at increasing value with increasing amounts of financial risk for providers along that continuum. This is a very simplified way of thinking about this. We could do a whole hour on APMs, But for the purposes of our conversation today, we're just going to focus on some very, very high level definitions. So on the continuum of APMs, they start with a basis of fee for service. So that's sort of not an APM. That is where we started. Fee for service means that providers get paid for what they do, regardless of the outcome. Starting the APM continuum, you have pay for performance, where providers get paid a little bit more for specific services that are shown to impact higher quality of care and or lower costs. So for example, getting a little extra for giving a flu shot or completing a developmental screening. The next is bundled payments, which is a lump sum to cover an episode of care, which covers all of the care a patient receives in the course of a treatment for a specific illness, condition, or medical event. A very sort of traditional episode of care associated with a bundled payment is a joint replacement, for example. And then finally, we have capitation, or one amount for a patient's total care. And there is the greatest level of provider risk associated with capitation. If the costs for a specific patient are larger than the amount of capitated payment a provider has received, they are at risk for that. If the costs come in under their capitated amount, then the provider gets to keep the extra. Next slide, please. So let's think a little bit about value in the care of children with special healthcare needs in the context of APMs. So there have been some studies using APMs for pediatric patients to date, and they can show decreased costs and or increased quality and or increased family satisfaction. But these studies have been conducted in specific clinical environments and with relatively small numbers of enrolled kids. So there are questions about whether those findings, those successful findings, are generalizable to larger populations of kids with special healthcare needs, and whether they're generalizable to other kinds of settings. There's wide variation across payers and states, which makes standardization challenging. There are underdeveloped consensus measures of quality from an array of viewpoints, providers, payers, and families. There are questions about to whom value accrues and to whom it should accrue. I think my colleague Jeff Schiff is going to speak to this in a little bit more detail in just a moment. If we're defining value using the quadruple aim, which is improving population health, reducing costs, enhancing the patient experience, and improving provider satisfaction, then looking at this multiplicity of perspectives in defining value and then figuring out mechanisms to get to value is a very rich and robust area for further exploration. Next slide, please. I'm going to turn the floor over now to my friend and colleague, Dennis Kuo. Thank you very much.
Hi, everybody. This is Dennis Kuo. Thanks, Meg, for the introduction to the next set of slides. I'm going to be spending some time talking about the research studies that are proposed within the paper that's in the supplement that we referred to earlier in Academic Pediatrics. We'll start by referring back to the 2017 to 18, the RAM process, the method that gave us a foundation for the priorities of topics of focus under finance. Within a multiple stakeholder process, iterative process that's outlined in the collar paper that Chris referred to earlier. We started with three different areas of focus. The first meaning that a payment model, what payment model might be improving, lead to improved quality of care for children with special healthcare needs. The second is what kind of return of investments do you have on care coordination? To have care coordination, whether it's a particular person or a program for care coordination, what kind of return of investment do you need? The third is what are the value outcomes for return of that are meaningful to stakeholders. We then took a literature review to undertake some gaps in knowledge of what is in the research area, and what we found was essentially what Meg mentioned, which is wide variation in current scope of models of practice, underdeveloped quality and outcome measures, meaning it was difficult for us to be able to look at our to be able to assess our financial return on investment, and also no consensus on really looking at appropriate constructs and paradigms of care, which would allow us to evaluate a financial model of care. So our stakeholders then looked at a range of studies which would really describe existing practices, practices of alternative payment models, financial models that would allow us to give a better landscape of what is actually going on out there. That would, to be able to describe the range of outcomes would then lead us to proposing next steps, assessing feasibility, and be able to move the field forward. Next slide, please. The first study that we propose is a descriptive study of alternative payment mechanisms, beginning with 5 to 8 case studies and examining how accompanying payment models would be able to influence the outcomes. So let's take an example. If you have a child, say with spina bifida, who requires multi-specialty care, care coordination, therapies, accruing services and costs, both inside and outside the healthcare system, it's helpful to be able to describe what different payment models, the impacts would have on this particular case. And because of the range of payment models that are currently available, as Meg had described, that gives us the possibility of describing what those different payment models, what kind of impacts on a range of things such as benefits and coverage, co-pays, networks, the things that are available under different alternative payment models. The results of this would then provide recommendations for pilot projects that would enable us to try to narrow down different aspects of alternative payment models. There were some things that we mentioned in our paper, including the impact of risk stratifications. For example, how do we identify different children and youth special healthcare needs and their needs that would be applicable underneath different payment models? The range of benefits that are covered, the different levels of co-pays, the contributions. The outcome of this study would provide recommendations for this pilot project, including experimental design and quality improvement that would allow us to be able to move the field forward. In essence, we're proposing a crosswalk of defined needs and different alternative payment models to be able to come out of this particular proposal. Next slide. The next study that we're proposing is to really more closely examine return on investment for care coordination with children and youth with special healthcare needs. And this one, we are proposing a quantitative study, being able to use different population data and different sources of payments and a range of outcomes. There are studies that look at care coordination with children and youth with special healthcare needs. What we are proposing is to look at this in a more expansive way, using a process called care mapping to be able to broadly look at the range of care coordination activities, the activities that are covered or would be touched by the active care coordination. We would propose looking at care coordination as the independent variable, either assigning an individual and or utilizing a care coordination measurement tool to be able to look at the activities that care coordination are doing. And the outcome variables certainly will look at cost and utilization, we'll look at service needs. When we're talking about the expanse of care coordination, we also have to consider not just what's in a healthcare system. For example, does care coordination result in reduced hospitalizations to emergency room visits? But what is the impact of care coordination on services outside the healthcare system? What about therapies? What about the education system? Social services? This is a valuable research question within an integrated system with multiple services, and also across different services, mentioning the education system where many of our children receive services, mental health system, different healthcare systems, different social sectors. There's a lot of areas where we can be looking. The next slide, please. The third area we propose is to address the question of what are the values that are meaningful to a range of stakeholders. This is where we are looking at a qualitative study, really defining what that value means. A number of the studies that we looked at in our literature review had really looked at the issue of cost to a healthcare system, but as we know, that is not the outcome necessarily that all stakeholders are looking at, whether it's quality of life, employment, impact on family members, impact on other services outside the healthcare system. And so we're proposing a qualitative study really using a variety of group and stakeholders, including parents and caregivers, providers, payers, educators, disability groups. And we propose using a human-centered design facilitated approach to really look at the components and the aspects of the journey in and across different systems. When we utilize the term human-centered design, we're talking about an approach that looks at the journey and the experience of the child with special healthcare needs and the family and the all of the providers that touch and care for the child. The purpose of this value outcome study is to really define what is right. What is the value, what is right that may not be currently captured in health system data. As we know that healthcare system data can be limited in being able to assess the outcomes that are meaningful to a variety of stakeholders, particularly families. Let's go to the next slide, and I will be turning it over to our friend and colleague, Jeff.
Good morning or afternoon, everyone. Thank you for joining us. I really appreciated Dennis's and Meg's perspective, and my perspective on this is probably a little bit more from the population based payer perspective. I wanted to just say that there's a lot of emphasis right now on value-based payment methods, and a lot of what the studies that Dennis proposed and a lot of work that's being done and articulated by the Center for Medicare and Medicaid Services is around moving to value-based models. Meg talked about the perspective of the continuum from fee-for-service to capitation. And I just wanted to spend a little time trying to put together some of these thoughts to say that if you're sitting at a payer organization, be it a managed care organization or a state Medicaid program, or probably the federal programs, there's a lot of things that have to kind of line up to get a value-based payment method. And for children with special healthcare needs, there are some unique challenges here that I just want to highlight as I go through this. These are the four components that really come about when you try to develop a population based value-based payment system. And the first is just simply to define the population either by complexity or by complexity. And there's always a tension about whether we're doing an episode of care for a specific disease, which is maybe easier and maybe very easy in adults where there's a lot of morbidity and mortality around hypertension or diabetes, but much more complicated for our population of children with special healthcare needs. And figuring out how to stratify the population for complexity is one significant challenge where there's been some great research on it, and we need to figure out how we can use that to apply to more consistently to payment methodologies. And I want to just say here also that we should talk about social risks and relational risks as well in defining the population as we learn more and more about their impact on health outcomes. Dennis talked a lot about what kind of model for care coordination and how to figure out the investment in the model for care coordination. And I think that and the effort taken is really another important area where multi-center studies could potentially give us a lot of information about how care coordination is being implemented. Measuring quality is something that I'd say I'll be frank, I think is we have a lot of measures, but how they're implemented in a value-based payment mechanism is really more nascent work. I think we've come to realize as we've tried to develop value-based payment models that we need to go to families and look at their experience of care. And on the other end, we need to look at real outcomes that matter to families, be it things like kindergarten readiness or family quality of life. And in between those two is really the idea of looking at some of these utilization parameters that are important and perhaps important for payers and easier to quantify, but certainly not important for every population. And then the link between the utilization outcomes and some of these outcomes for families, I think is really important to study as we look at measures as well. And last, as far as last but not least, is looking at how these payment models are incrementally used. And I don't know of anyone who has turned a switch on and all of a sudden there's a payment model that's fully formed for some sort of a capitated full risk model that everybody is happy with. So I think that there's really a continuum here. All this is to translate into some incremental improvement, hopefully. And I think that one of the challenges we have is that since all of these pieces need to be in place, it's hard to figure out where and how to pilot and how to get how to get that going. And I will say that I think states through their Medicaid programs have the potential to be laboratory and are already laboratories for some of this, although I'll say that a lot of the work has not gone into children with special health care needs. But things that we could quantify are things like just understanding how many payment types are out there from different kinds of along that continuum, understanding how risk is shared so that we can bring in systems that can't take on high risk, but would be really interested if we can protect them from risk, understanding how MCO contracts work for these sorts of things. Next slide. Just a couple other thoughts from the payer perspective. I think we need to understand that that insurers and Medicaid programs work with the data they have. The better data, the more data, the better. But sometimes sometimes the amount, for example, the amount that they pay, you'd like to think it was exactly based on the work effort and the salaries and all that sort of stuff, but it's often more of a negotiated thing. We need a sound construct for the model from the payer perspective, so they know that they know what their payer what is being paid for. As I said earlier, we need measures of both outcomes and of processes of care. Here, some things, some processes like having a care plan or having contacts with patients are often valued by payers. I think there needs to be, we could study, and I think we should commit to looking at involvement and ownership across a broad swath of health and other sectors, so that from a payer perspective, I would say, as well as from all of our perspectives, if you come to to understand the importance of having involvement of children, youth, and families in the model and in the development of it and in the ownership of it, I think it goes a long way at the payer perspective as well. And then we just need to be able to understand that this is incremental, that we're making these steps incrementally. And I think we have to just keep on going to make sure that we go further into risk stratification or further into better quality measures. But I think if we own it together, it's more likely to happen. Last, I just wanted to, next slide, and my last slide, I just wanted to bring up the issue of using research dollars and to understand and challenge all of us to make sure our research dollars are used wisely. What I said before about ownership in the product goes also to ownership in the research, that if we can co-create research with families and with Medicaid and other insurers, we have a much higher likelihood of understanding where and what we get researched. We can talk a lot about scaling up what we test, so we make sure that a pilot is implementable across other systems and not just localized to a specific system. And I think we really have to start thinking of some of this research as continuous quality improvement that we're trying to do at multiple sites at on a national level. And the last thing is making sure that we call on our colleagues who control more of the funding in healthcare to participate and to think about their responsibility for moving this from dissemination to implementation. It'll be new to them too, but I think it's really where we need to go, probably from early on as we start the research. With that, I'm going to turn this back over to Chris. Thank you again.
Great. Thank you so much, Jeff, and thanks to Meg and Dennis for a great summary of the financing research agenda paper and a lot of good questions. I do not need to ask you to ask questions because there are already probably 7 or 8 great questions that'll take some time. So thank you for that. I would again try to direct you to the research agenda supplement in the March issue of Academic Pediatrics that was put in the chat. Each paper, including the financing paper, summarizes what's known briefly, gaps in knowledge, and then recommends some ideas for research projects that could be done to help to answer some of these questions. As far as I know, none of the projects are actually underway, nor are they funded or ongoing, but they're ideas that many people who do research could do potentially to help coordinate solving those questions. I'll just ask one quick question and then we'll have a lot from the audience. For really any of you, we know so much about alternative payment models and how they might meet adult needs. What research involving alternative payment models should be done to distinguish models best suited to children and youth with special healthcare needs from those suited to adult models? Ideas?
This is Dennis Quo. I'm going to take I'll take a first crack at the answer. One of the biggest things that distinguishes pediatrics, the pediatric field, compared to the adult field, is the emphasis on something that we call the life course model. And the life course model, it looks at the unfolding or the development of health and wellness, from a child going all the way up to adult, and understanding that specific interventions and things that are done, paid for and supported by services at specific times have large impacts down the road. And this is particularly true for children and youth with special healthcare needs. The alternative payment models, I think we need to be looking at in pediatrics should be looking at those programs that support the life course model. In adults, the model is to pay for rehabilitative services, for example, but in pediatrics, we talk about habilitative services. There are also other programs under alternative payment models that are looking to be supported in APMs. That includes programs that promote two-generational care, parenting practices, relational health practices, and I think those are some areas where more of that research needs to be done, particularly as pertains to children and youth with special healthcare needs.
Great. Thank you, Dennis. Another question directed at Meg Camo. Can you speak more about your finding in the paper that you cited that families who have public insurance report better care coordination than those who get private insurance?
Well, I really hope that I didn't misspeak and mention care coordination in that context, because the point that the data shows us is that families of kids with public insurance, Medicaid or CHIP, have greater adequacy of coverage, they have better benefits, and they have more continuity of coverage. So I think that if you're defining sort of value based on continuity or quality based on continuity and adequacy, then those are two measures that you find more typically in public insurance. There's also the aspect of affordability for families. There are very limited, either no cost sharing or very, very modest cost sharing allowed for Medicaid and CHIP for kids in general, including those with special healthcare needs. So those three measures of quality are the point that I was trying to elevate through that data. Not so much around care coordination. Care coordination is a challenge across the board, regardless of payer, unfortunately. And so I think that's one of the reasons why return on investment in care coordination is an emphasized research topic, because it's so ripe and rich and ready for improvements. Thanks.
Thanks, Meg. I'll just kind of go in order because they're all good questions. One listener would be interested in hearing more about family-centered outcomes that could be used with value-based payments. And Dennis, maybe I'll ask this of you because you mentioned it when you were talking. How might we identify those outcomes? How might we use those outcomes? And do you have any thoughts on what they might be?
Yeah, I have plenty of thoughts, and I think those are great questions. I'm going to come back to the human-centered design approach, because that's something that we mentioned in our paper in this presentation. And there's also a related question in the chat about the different stakeholders that might be part of that process. The idea of a human-centered design approach is to be able to look at the entire journey across different experiences and systems. And that is really very much centered on the person or the user, or in particular, the family. And so outcomes that might be identified when you look at the journey would include things like, what are the things that are important to families? And I think that is the iterative process that comes out. There's some literature that looks at things like missed school days, missed employment days, family finances. There's a number of social drivers of health that can be impacted, that can be identified within the family-centered care approach in literature. Some other things might include family stressors. There's one of the things that comes up in the human-centered design approach is to look at the emotions, the stress, or the need for empathy as we design a system and we support it through research and finance. It's a really broad topic, and I don't want to begin to say like the range of outcomes that may be identified, but I wanted to present those as there's some past literature in it, and there's some things that are identified through human-centered design approaches. Great.
Thanks, Dennis. Yeah, I think it's very key to think about human-centered design as a research technique to really use, techniques like appreciative inquiry in involving family views to get outcomes that are more relevant to their day-to-day experiences. Okay, another question to Jeff this time. The methods that you proposed in your studies of Medicaid programs, are they meant to be standardized within a given state or across states?
I think there's a lot of opportunity to standardize them across states, Chris. I think that I'll just say that some MCOs operate across states, for example, but they may run different programs in different states. I think that if we could get some greater understanding of how one state uses a bundle of care and then how that compares and what the outcomes are, I think that would be really helpful. I feel like with those 4 things I told you, I feel like it's a little bit of which one are we going to lock down first? Because if we can lock down sort of the complexity of some understanding of the complexity of the kids, and even some of the measures that Dennis was talking about, whether we start to look at utilization and some family-centered outcomes, we can then see the impact of the payment models on that. But if all these parts are always moving, it's really hard. And I think because the states are really the developers of these programs, and I would say, I think in a lot of cases are really hungry to figure out how to develop these better, we have the opportunity to help them to participate in some of these research questions.
Great, thanks. Right, here's a good one about transition age youth. One of the listeners asked about how research might address the changes families experience with moving between health plans during transition ages in terms of outcomes and improving that process. I might take a stab first. I think maybe one thing is to decide on the outcomes we want to look at together with youth and families, and then go from there, because I don't think those are well defined yet.
This is Dennis. I'll take let me venture another thought on this. When we're talking about large data integrated systems, be able to capture the individual, like an individual going from the pediatric system to the adult healthcare system, that gives you opportunity to be able to look at what happens around that age. Some of the literature there does raise questions about whether somebody who goes from the pediatric healthcare system to the adult healthcare system does drop out of regular continuous, really medical home type care for a period of time, and looking at the costs involved within that during that transition time, and how long those individuals may stay out of the system. I think one of our challenges there is ensuring that we do ask these questions from an integrated standpoint. I think one of our challenges with the National Survey of Children's Health, for example, is that it's focused on children, and then when you look at adult healthcare data set, you're looking at adults, and we've really got to look at data sets and research opportunities that allow us to get past that cutoff, that may be somewhere between the ages of 18 and 21.
Chris, I just want to chime in and just say that I think there's a fundamental question here, which is adequacy of insurance for kids as they transition, because it seems like we sometimes look at things like their providers or the network of providers and whether they're getting the services they need, but so many kids in so many states as they transition to adulthood, we really don't know enough, I don't think, about whether or not what their gaps in coverage are and how they're getting their coverage, and and what those challenges are.
Great. So here's a question sort of related to how to integrate the neighbors, the medical neighborhood participants and stakeholders into research. specifically home care providers, how to integrate home care providers into the research model that where, typically it just looks at payments for direct medical services back and forth. Any thoughts? It's a tough question.
This is Dennis. I'm going to chime in with an observation. It may not directly answer the question, but in looking through the chat, there's a related number of comments and questions I just want to comment on. I think it'll touch on the home care. We're really proposing not just a kind of a broad look at what's available out there, but we're also asking folks to really kind of rethink some of the fundamental methodology that's being used. For example, if you look exclusively at a healthcare system, you'll get what's in the healthcare system. There's one technique that we propose is the use of human-centered design. We've talked about care mapping to get an expansive use of look at the system that care coordination and care coordinators would be touching, really to use that as the foundation. There are other aspects such as like when you're looking at different sectors, you have to look at an integrated care model or an integrated system, or be able to develop contracts allowing us to look at cross-sector costs, braided funding, hybrid funding models. Those are the ways that when we're talking about healthcare financing, we know that there is both downstream impacts on other sectors as well as impacts of other sectors on healthcare financing. So these are not easily answerable questions, but getting the landscape and the variety and some of the really innovative models out into the literature is really the foundation of what we came up with in this paper.
Mm-hmm.
If I could follow up on that with just maybe more of an editorial comment than anything else, I think that not only home care, but home and community-based services in general, if the view were taken that they are an integral part of the healthcare system and also an integral part of improving value, because when you think about the spending on home and community-based services, it's really around the return on investment and keeping people out of more expensive institutional care. So if we thought about it that way in a little bit more comprehensive, from a more comprehensive standpoint, it's part of the continuum of care. It's part of the continuum of the experience of being a person with a disability or special healthcare need. If we thought about it in the context of quality of life and well-being, if we thought about it in all of those other different contexts that inform the quadruple aim, I think it might help get us a little farther down the line than we might be otherwise. I have to also feel compelled to highlight the uncompensated care that families provide to children with special healthcare needs at home that goes completely unrecognized by the system. They are the backbone upon which pretty much the whole thing operates, and there's no sort of acknowledgement of the value that they contribute to the system or any kind of financial compensation for a lot of the care that they provide. So I think looking more holistically and looking more expansively on home and community-based services and long-term services and supports as the foundation for everything else above it could be just a different way of thinking about things that could help improve value and help sort of fulfill the mission that we set out in the title of the paper, which is moving from spending to investment.
Mm-hmm.
Chris,
thanks, Mary.
Because I just want to add, if I can, just really quickly, that I think one of the areas that will be really ripe for research and more fundamental is just how these, the home care or LTSS or home and community-based services or other services are communicating with the medical side. Because I feel like that, that ROI on care coordination we talked about, it's so crucial to understand in those systems, whether there's ongoing communication, whether there's ongoing dialogue, whether there's you know, whether they just fire missiles across the wall at each other, you know, sorry, but you know what I'm saying, where they just kind of, you know, where there's things, reports sent back and forth, but not any dialogue. So that would be a really useful thing to look at, that value.
Great, thanks. All right. There's a sort of a suite of a couple questions that I'm gonna try and answer and also post to the group together. There was a question about how engaged PCORI, the Patient-Centered Outcomes Research Institute, is engaged as a funder for this work. And I think that the answer to that is they are not currently engaged, but the network that we're part of plans to engage funders in the upcoming year to 5, should we get refunded, to identify funding needs and to establish more dialogues. A lot along the lines of some of the success that we've had with funding with the Packer Foundation, actually. Related to that, there's a great question that I'll post to the group. If you had a magic wand, what would you recommend to funders, especially federal agencies, to help realize the research agenda related to financing?
I'll answer Allison's question with, I would love for there to be a unified effort around measurement between MCHB. I mean, there's these kind of measures that we need, like are the population-based measures, but we also need these kind of measures that are specific to families and to utilization of services and to measures that require linking data between Medicaid and maybe vital records or other programs. And I think that that's maybe more in the infrastructure, but I think we would get farther if we had some of that integration.
I would second that and want to add, I think, you know, if I had a magic wand, there would be more quality measures that are specifically targeted to things that are important to kids with special healthcare needs and their families and their providers, as opposed to just sort of these narrow clinical measures. And as a result of those improved quality measures, there would be greater accountability in the entire system for where the money is going, how it's being spent, and what return on investment is coming from it.
One other magic wand I'd like is to be able to have clean data as much as possible, to be able to share it among payers. There's a lot of data out there. It's not being used for research purposes. It wasn't designed for research purposes. Some states and some payers and colleagues have better data than others. But you know, investment to be able to create accessible, clean data to be able to utilize these measurements that we're talking about, and across systems as well. You know, some way to be able to focus, to be able to, for example, get across the HIPAA-FERPA divide or you know, or landscape. You know, we've talked about the places that have all payers claims databases are an excellent start, but being able to put like really a truly integrated data system to be able to examine these outcomes is where my wand is.
Great, thank you.
Chris,
All
can I
right,
say-
we've got one.
Can I
Sorry.
say one thing real quick about PCORI, just to say that PCORI's re-up financing included their ability to look at the value of programs and research they do, which is new from their prior 10 years. So I think there's an opportunity to engage PCORI around that as well.
Okay, great. Oh boy, so here, we only have 1 minute, but this is sort of more food for thought. For 2 decades, we had heard all the reasons why telehealth was so difficult to implement. Then in 2 weeks in March 2020, pretty much everyone figured it out. Do we need a similar leap in alternative payment models, and how would this go? We could talk for an hour on that, but I just think it's a really interesting question to start to end with. Okay.
You know,
Yeah, go
So
ahead.
at the very bottom of my feed, it talks about return on investment. I just want to highlight another comment. Meg made this earlier. We are talking about moving from spending to investment. Our children with special healthcare needs, we need to invest. And being able to try to put all of this on a cost savings that may or may not actually be there, but we need to recognize the investment that we need to be putting into all kids, and some kids just need more resources than others, and that does go into the area of outcomes and value. And we talk about what is the what is the thing that we can suspend. I think we have to be looking at an investment and not what can we cut out of the pie.
That's right. Thanks, Dennis. I think that's a great note to close on. So thank you all for your great questions. There are several more that we might be able to answer later on, but really appreciate the dialogue. And there's a lot of non-question dialogue too, which was really great. So appreciate that. This will be posted on the website, as are all the articles in the supplement. Please visit the Packard website for this and much more. And really appreciate the participation of all, but especially of Dennis, Meg, and Jeff. So thanks again.
Thank you.